any questions about what we've covered so far? Like I said, y'all are probably brain dead from your test, and I understand that. If you think about anything, always let me know. The other thing I will always ask y'all is if there's anything that I can do to improve getting the information to y'all, please let me know. I used to be sensitive, but now I just don't care. So you can tell me whatever you want to, and that's fine. Please make it constructive, But if there's a better way for me to teach or whatever, I'm always open to that kind of thing. All right? Cool. So now we're going to talk about chest trauma. Never occurs around here, does it? What is a pulmonary contraction? Contusion. Contraction. Pulmonary contraction is when you breathe, but pulmonary contusion. What's a contusion? A bruise. What's pulmonary? Lung. Okay. So it can affect the way the lungs respond. Remember, the chest trauma patients are the ones that are likely to get ARDS. So you be mindful of anybody that's got, a traumatic injury, because anytime you damage that lung tissue, it just puts them at risk. A rib fracture, duh. What do we do for rib fractures? Nothing. What can you do? You want to make sure that when you wrap the ribs, you wrap it all the way around their chest, right? And you pull it really tight. No. Because that way they can't breathe. You only do that to your ex-relatives or whatever. But it's really, it used to be that they would wrap ribs and everything, and it was kind of splinted them and all that kind of good stuff, and they realized that we're actually killing more people than we're saving. Now it's gotten to the point, we learned at the trauma conference a few years ago, that depending on the rib fracture, if it's displaced, you run the risk of puncturing the lung or puncturing the pleura, and then you develop a pneumothorax. Ooh, look at that right there. So what they've decided is sometimes they'll actually have to go in and surgically repair the ribs to prevent the patient from further damage. So now that it's a case-by-case basis, it's not everybody that fractures a rib gets this, but it just depends on the patient. All right? Flail chest. One of the coolest things you'll ever see. The definition is 3 or more adjacent ribs in 2 or more places. So you think about your ribs. So it's 3 ribs that are together in 2 or more places. So what happens when you breathe in? What does your chest do? It expands, right? And when you exhale, it decreases. All right? In a flail chest, when you inhale, the side that is unaffected, or the non-broken side, will do what it's supposed to, but the other side will sink in. And when you exhale, it's just the opposite. That's why it's called a flail chest. Because air is not going where it's supposed to be, because the rib cage is the protector of the lungs, and it's not doing its job. It's allowing it to expand when it's not supposed to. All right? What is a pneumothorax? It's a who? Okay. I can only hope my drawing will be better than that idiot that has the video. I'm sure you will. And I am so excited to hear this. Okay. All right. Dear Lord, let me go. And I know I'm not, so, okay. So here is your trachea, and then you branch off into the ribs. It's going to look the same way, but whatever. And you've got your ribs that go around here, right? Okay. And then it comes down like this, and your heart is here, and it comes back around here, and you still have your ribs. Okay? That's an enlarged prostate. No. Okay, around here is called the pleura, right? So what is the pleura? What's the definition of pleura? A tough, fibrinous lining surrounding the vital organs, doo-da, right? Okay, what's between the pleura? What's between the pleura and the lung tissue? Slime. And what it does is that slime, when you breathe, the pleura really doesn't move, but the lung inflates and deflates and it slides. Because if not, you get what's called pleural rub. But anyway, but it allows it to slide and not hurt. So when you, and it also provides protection from the outside. Well, if you rupture this right here, if you rupture that pleura, because in here and in here is negative pressure. Okay? You realize that when you breathe and your lungs expand, it's because your diaphragm pulls down and it pulls air into you, right? Everybody understand that? It took me a long time. I thought you just breathe in and everything just filled up, but no, it doesn't. So what happens is the positive pressure rushes in and causes this to turn into a little bitty uninflated lung. And that is a pneumothorax. Now, if you fill, well, that's a terrible drawing. But if you fill this up with blood, then you've got what? A hemothorax. What's the treatment? A chest tube or needle decompression. Take your pick. Needle decompression is your emergency thing. The chest tube is what you need. So what they'll do is they'll cut, like your body's out here, they'll cut a hole. Have you ever seen a chest tube put in? They take it, and all they do is they slit the skin, and then they take some forceps and they stick it in there, and they start spreading muscle apart with their fingers. And then they'll take a tube, and they'll try to get it right here. And then they'll hook it up to what? Wait. It's got to go to suction. And because there's a water seal in the suction canister, it creates a negative pressure again because you're not allowing the air to come back in, and what you're getting is negative pressure in here and the lung expands. That's how a chest tube works. It also sucks the blood out because it's hooked to suction. So when you have a pneumothorax, that lung is basically useless. Are you going to hear lung sounds over it? No. So that's part of the assessment that you have to do. If you've got fractured ribs, you can suspect that. If you've got flail chest, you can suspect that. Any type of chest trauma, you can suspect it. We had a guy that was in the hospital at Anderson's last semester who was walking to the hot dog stand at a T-ball game, and he had a spontaneous pneumothorax. Don't know why. He stayed with a chest tube forever. Then he developed other issues. But you'll be responsible for managing a chest tube system. But the key is when you have a rib fracture, flail chest, you can suspect a pneumothorax. And if you got both of them, it's called a pneumohemo or a hemopneumo. So, and we'll talk about tension pneumothorax in just a minute. So your responsibility is understanding that if you suspect that, you have to act because you're going to lose lung sounds on one side. Okay, this may be da-da-da-da. That's a bruise. Potentially lethal, maybe asymptomatic, and later develop all that. Rib fracture, often caused by direct blunt trauma. I don't know what else would cause a rib fracture. Who's at risk? Old people. What do they like to do? They like to fall. And usually what do they hit? I'm sorry. My big head. Oh, they like to hit everything. They like to hit the toilet when they fall, when they get out of the bathtub. They like to hit the dresser, the chair, the concrete, the steps. So they're at risk. It moves. You can get them to splint their chest by using like those pillows that they give you when they split your chest open to work on your heart. But uncomplicated, which means they're non-displaced, will reunite. How can you tell? Well, because he quits hurting. But you're not going to do anything. And really, all you're going to focus on is drugging them. Why? Y'all hear that? If you're hurting, you ain't breathing. What about your patients in the hospital who just had abdominal surgery, chest surgery, or any type of surgery? If they're hurting, they're not breathing. Y'all know that whole thing about turn, cough, and deep breathe? There you go. So all these things that you've learned still apply. This is just a traumatic experience. And you do want to focus on that pain management. Now, what's the problem with pain management? Okay. If you give them too much and they OD, they'll make them hypoventilate, right? Constipation. You know them old folks ain't going to like that. But I mean, you think about it. You're trying to provide pain management for them so they can breathe, right? What's the number one concern with pain medication? I am going to get hooked on it. Sugar Bear, you 93 years old. You can get hooked on it if you want to. But if it's taken properly, the risk of addiction is very small. And that's what you have to explain to them. We need to focus on this. Don't take it more than you need it. Don't take it if you don't need it. If you can get by with Tylenol or acetaminophen, knock yourself out. But we need to make sure that you're breathing so you don't have any complications. Well, what kind of complications could they get? Pneumonia. Right? What else? Muscle weakness. Atelectasis. All that kind of stuff. All these complications from not breathing properly. All right? So you're going to have to explain it to them. Because Mammoskis don't like taking them Lortabs. I saw Johnny take them and he got hooked. And now he's a crackhead. That's because Johnny was taking 17 a day. Okay. This is the flail chest. It's paradoxical chest movement. Flail chest sounds better. But you see where the flail is? How it goes out on expiration and in on inspiration? You will not miss this. So what are we going to do? That's going to be fixed. Here we go. Another video. Hopefully this one doesn't have the horrible drawings in it.
Chest injury in and of itself is the second most common type of traumatic injury that people sustain. So when you have a chest injury patient, outside of what we're talking about, there may be multiple systems that are involved, and thus why your patient doesn't tend to do very well. What I'm going to focus on here are 4 of the major chest injuries that have an effect on either ventilation, perfusion, or respiration. And obviously, since those 3 processes are necessary to keep us alive, the chest injuries that can interrupt those processes are obviously very, very dangerous and can quickly cause a higher mortality in your patient than, say, some of the others that are a little bit more benign. So the first one is the flail chest. And it's one of those types of injuries that often gets missed by EMS providers. And it's not for lack of trying, it's just that everybody expects to see the characteristic paradoxical motion in that particular patient. When you've got a fracture of at least 2 ribs in 3 different places, you have a very unstable portion of that chest. The rest of the musculature that surrounds the ribs, as well as the skin and obviously the pleura that holds everything in place in the thorax, kind of tense up when they're disturbed like this. And when that segment tends to move, it doesn't move very much. And the way it usually gets discovered is that you will have someone palpating the chest, and all of a sudden they'll feel that segment as they go over that particular area. The problem with this is that, among other things, it majorly can compromise a patient's ventilation. Here's how. The segment in and of itself, when it's moving, is now unstable. And you have broken rib ends that are basically rubbing up against one another. That in and of itself really, really hurts. So as a result, your patient doesn't ventilate very well, and they just take a shallower breath. And that's what we call splinting. If that flail chest is a little bit bigger, so say it's more than 3 ribs, say more than it's half the chest, let's say, the bigger that flail segment becomes, now what you also have a problem with is the actual expansion of the lung itself, because you have the visceral and the parietal pleura. And you have the visceral layer that lays on top of the lung, and you have the parietal layer that lines the inside of the rib cage. And that's what kind of holds the lungs to the ribs. So as the rib cage expands, it pulls the lungs and creates the pressure differences that allows us to breathe. Now, you still have that connection intact. But the problem is that the rib cage isn't intact. So now this opposite motion does not allow for that portion of the lung to actually expand adequately. So add those two factors together, and now that patient's ventilation status, in some cases, can be pretty well compromised. So how do we fix that? Well, we get them to surgery is the best way to fix it. There's really not much that we can do for this in the field to remedy this. And that goes with any traumatic injury. You know, these people need surgery, so that's what we have to do. We stabilize them as best we can and get them there. With a flail segment, the best management practices now center around two things. Now, as an EMT, you only have one option, and that is to assist them as you can with their ventilation. Allow them to ventilate on their own as best as they can, but if they need assistance, you help with that, whether it's using a BVM. In some places might even subscribe to using CPAP to get a little extra pressure just to help keep that ventilatory volume moving through the respiratory tract despite the pain. Now, if at all possible, and if you're working with a paramedic, what you'll want is some kind of pain management, some kind of analgesic. It kind of takes the edge off, and that, all combined with the effective ventilation, would hopefully supply enough volume that adequate respiration would be able to take place. Outside of that, it's pretty much diesel therapy, and we get them to the hospital as safely but as quickly as possible so they can get surgery to repair that deficit that has been discovered.
All right. So that was actually a pretty good explanation of how you handle a flail chest. Now, this was actually from an EMS standpoint. However, as a nurse like if your patient falls, which our patients are never going to fall, are they? Never. But if you suspect that, that's about all you can do is try and get them somewhere where you can get surgery for them. Because the flail chest, those ends are separated. It's unstable. I don't think I'm recording again. Really? Now, maybe I do this. My mic is muted. So you're going to focus on pain management and getting them to surgery. That's all you can do. We as nurses don't have the ability to fix a flail chest. We can help them breathe, but like I said, that's it. But you understand what causes it and what's happening when they have that segment that's unstable. All right, a tension pneumothorax is when it is so severe that the trachea begins to deviate because the pressure inside. Okay, you realize one lung has negative pressure. You've got the pneumothorax, which means you've got positive pressure coming into it, right? So far, so good. Well, what happens in a tension pneumothorax, you keep increasing the pressure on the injured side, and it just creates this big blob of pressure. So everything starts to shift, including the trachea. Now, this is a late sign. Tracheal deviation is always a late sign. But when you start doing that, everything is shifting from here to here. Well, what's in between your two lungs? Your heart. Well, if you start compressing the heart, what are you doing? You cramping. No, what? What are we doing with it? If I've got the heart here and I'm pushing on it, and it can't go much further, can it? So what is it going to do? It's going to compress, right? Well, if my heart is supposed to be doing this, and I start compressing it, what's going to happen? We're not going to have adequate confusion. We're not going to have adequate confusion. No, there's lots of adequate confusion. We're not going to have adequate perfusion because we've compressed the chest and compressed the heart to where it can't recoil and refill. So our cardiac output's going to stink. Well, how can we tell if our cardiac output is down? You think? Think their blood pressure is going to go up or down? Okay. What do you think their breathing is going to try and do? It's going to try and increase because now we're going to start trying to compensate. What do you think their pulse is going to do? It's going to try and increase. So this is dire. You've got to get this shifted back the way it's supposed to go to allow that heart to expand and contract the way it's supposed to. In addition to oxygenating the patient, because once you start compressing this lung too, you're not going to be able to expand it as well. I mean, this is just a cascade of disaster. So once that happens, that patient, you can write them off. Once it gets too bad and you can't get everything shifted back, because they will lose perfusion, they'll lose oxygenation. So when you see this, what's the cure? A chest tube. You've got to get this lung re-expanded. That's the only way it's going to work. Okay. I get to quit talking. So, a 61-year-old female client underwent a hysterectomy. She's got a hysterectomy at 61. Okay. She's brought to the ED by her husband with a new onset of shortness of breath. He reports that his wife has been in bed since surgery, discharged because she was very tired and felt short of breath when she got up. What are her risk factors? Age? 61 is old. Be careful. She's post-op? She's what? She ain't been moving. What else? She's short of breath. Is that a risk factor or a sign and symptom? Okay. What else? She's female. The only thing it don't say is if she's overweight. What else is she? Did y'all say post-op? Yes. Okay. Sorry, just missed that. And the answer is prolonged immobility, advanced age, and recent surgery. Yay. She's going to die. No. So what do you think that they're going to do for her? What do you think she has? She may have a PE. So now what do? You investigate. Because she's going to be on what? What do we do for PEs? First we got to find them, right? Chest X-ray or CT. We're going to look for everything on her though, because we're going to look for a VTE, right? Some type of blood clot somewhere, because if she's got them in her legs, chances are she may have them in her I was going to say in her stomach, but that didn't make any sense. She's going to have them in her lungs too. And we're going to check her D-dimer. Very good. All right. During triage, the nurse records these assessment findings. This may be acute respiratory failure that we didn't talk about. Temperature's 99.4, high or low? What is the definition of a fever? Over 100.4. So normal temp, what is that? Sinus tach, what does that mean? Her rate is above 100. She ain't got no oxygen. All right. Blood pressure, that stinks. Respiration stink, and she's got crackles. What are crackles? Fluid, right? That what it sound like? So what do we anticipate? Respiratory failure. She may have a pulmonary embolism. She could also have pneumonia. Or she could be just tired. Okay, so this is the same lady, but she may have a PE because she could also have pneumonia based on what we saw, right? because she had the surgery and the immobility, which are hazards, which cause pneumonia, and now we got to look even further. Good Lord. Why can't folks just come in with one thing? I got the diabetes. Take care of it. All right? So, the triage nurse immediately mobilizes the client to an emergency bay. Yeah, like that's going to happen. The healthcare provider sees the client immediately. Like that's going to happen. Okay, so of all the things, are all those things stuff we're going to do? Which order will the nurse complete as the priority? I don't know if I'll agree with this one or not. To me, it would be the oxygen. But look at this right here. It says she's going to provide these orders: the O2, the stat lab, stat CT, and an IV. Based on the client's pulse ox, the next priority is the administration of oxygen, because that's going to be your priority right now. Now, is it always? No. The saline lock should be started. Why? Okay. So what also can you do when you stick that line in them? You can go ahead and get your blood. Always be as efficient as possible when you're dealing with your patients, because the less times they have to be stuck, the better they like you, and the more likely it is you're going to get a raise. Actually, you just don't want to stick them, over and over and over, because if you can get the blood draw on your IV start, go ahead and get it. It's just one less thing that you got to do. All right, so you get your lab, and you send that to the lab, then you get the CT. Plus, like you're right, you can do it as a contrasted study. What do you have to find out if you're going to do a contrasted study? Allergies. And a BUN and creatinine. Why? Kidneys. Contrast does what to kidneys? Kills them if you do it too much. All right, so now, while in the treatment bay, the client asks, see, you got to pee. Ain't that how it always works? Okay. They got an aid. What kind of ER has an aid? I want to work there. In the NCLEX world. Okay, which AP action demonstrates to the nurse that this task has been safely accomplished? A, B, C, or D? Okay. Why not D? Okay, but it says have her wait until the shortness of breath subsides before she goes to the bathroom. You gonna tell Mama Skeets, no, you can't pee right now? She gonna pee one way or the other. Okay, so why not ask the nurse to have a catheter put in? Why not? Exactly. What about B? She's already short of breath. Don't take her oxygen off of her. So A, put her on a bedpan. What's the problem with bedpans? You got to figure out. Well, I mean, it's the safest, right? Because she gets to keep her oxygen on. She's going to protest that, and what is she going to tell you? I can't go on one of these things. Well, you're going to have to. Go or hold it. She probably came in smoking a cigarette, too. Y'all seen her. Y'all know Mama Skeets, the little wrinkled lady? That was her. Okay. But anyway, yeah, it would be the safest thing to put her on the bedpan. And you're going to have to just talk folks into it. Okay? So we talked about all that. All right, 2 hours later, she's admitted to the unit where she started on continuous IV heparin on a weight-based protocol. Which finding indicates that the heparin infusion is therapeutic? I'm not going to ask you lab values, but why is A not right? That's for warfarin. What about B? Same thing. What about C? They're not anticoagulated at all. So it's got to be D. Okay. Y'all understand how this is actually checked? Do you even care? Okay, it's all in seconds. All right? So if it takes you normally 14 to 18 seconds to clot, the APTT, if it's 1.5, it would be 1.5 times 14 to 18. Do-da, whatever. You don't need to know that. All right, 3 days later, they're going to discharge her. They're discharging her with a PE? Well, it must have resolved. Okay. So what do we need to do? We need to follow up. B. A, B, and D. Okay, what can you tell her about her greens? What she said. Be consistent. If you eat a salad and a helping of turnip greens every day, continue to eat a salad and a helping of turnip greens every day, because they can get your blood corrected with that diet, but you've got to be consistent. Most people find it easier not to do the foods high in vitamin K just because, but it doesn't mean that they can't have it. So it's A, B, and D. All right. Here we go. What y'all think? Why not D? Huh? She's already being treated for infection. All right. So y'all say A. A. All client scenarios create a risk. However, the trauma client is the direct chest with the direct track. The guy that got hit in the chest is at greatest risk because he's also aspirated. All right? What y'all think? It says he should limit his alcohol consumption. So which one is wrong? A is right. He needs to cut his alcohol consumption out. I should limit my alcohol consumption. B. Frequently discharged on anticoagulant therapy, they should be educated to understand the risks and monitoring of this drug, include weekly monitoring, consistency in dosing, foods to avoid, leafy green vegetables, green tea, alcohol, and cranberry juice. Now, if he says he should limit it, why is that wrong? He should stop it. But the biggest thing is the leafy. Okay, what can cause respiratory depression or respiratory failure? D. Because you're talking about something acute, that's an extrapulmonary cause of ventilatory failure. Is a pneumothorax extrapulmonary? No. What about amyloidosis? Pulmonary edema. Them folks on drugs are going to quit breathing on you. All right. One more thing, and then we'll be done for today. Oh, yes. And you get to keep these right on them if you want to. If you came straight out, you will. Well, actually, the text came straight out. If y'all want to I was going to say if y'all want to coagulate, y'all can. Y'all know what I mean. Yeah, just as tight. Cooperate, ask your neighbor, phone a friend.